I'm Jane Buxton, and I'm a professor in the School of Population and Public Health, and I am the harm reduction lead at the BC Centre for Disease Control. And this is a follow-up presentation, having given you one on the theory of mixed methods research. This is to give you more of a program evaluation. And the example I'm going to give you is a very topical one, which is about the take-home naloxone program. So in BC, we noticed back in 2011 that there was an increase in illicit overdose deaths, and this led us to realise that we needed to do a much more intensive training for people who use drugs around overdose prevention, recognition and response. And a program was started in August 2012. We developed the Overdose Survival Guide to help people and to remind people. And we obviously were not just targeting people who use drugs, but their family and friends and service providers as well. So part of the response is take-home naloxone. Naloxone temporarily reverses opioid overdoses. It acts in about 3 to 5 minutes. It's an antidote, it has no effect on its own, and it is very safe to use. People who use drugs, their family and friends and agency staff have been trained to administer the naloxone in the community. There's been many studies performed in the US as they've had take-home naloxone programs for the last 16 plus years, and they found that it does not increase drug use, and it can be safely administered, and people in the lay public can be trained. When it's administered intramuscularly, it can be given through clothing, so it does not delay a response. However, in Canada, naloxone is only a prescription-only medication, which means it must be prescribed and dispensed to people who use opioids. It cannot be given to the family members. But of course, it can be used by the person who owns the kit on another person if they see them in distress, or their family or friends can use the kit upon them if they have an overdose. We routinely collect data. We have numbers around who is trained, who has received a kit, and administration forms when naloxone has been administered, to collect details about the circumstances of the overdose and of the outcome. This is a picture of the naloxone kit. It's actually a new case that we've just discovered, and we've done some evaluation as we've gone along. We're nearly up to 3 years now, and things have changed due to our evaluation. We started off having black glass sunglass cases, so they were rather incognito, so that it wouldn't be obvious what people were carrying. But we heard that people really wanted to show off that they were naloxone trained and that they had a kit. We also heard that it was hard to find in a backpack when it was black and dark, so we added the white zip to it. As you can see, it now has a red cross and naloxone written on it. There are 2 ampules of naloxone in the kit, and we found initially that people were cutting their fingers, so we added fairly rapidly the amp snappers to avoid that happening. And we added a simple face shield. We had a more complex one previously. And the syringes they're safety syringes, so that after the naloxone had been administered, the needle retracts. So we know that naloxone lasts about 30 to 90 minutes, but if somebody has had a large amount of opioids on board, the overdose may return as naloxone wears off. Therefore, part of the training of the overdose recognition and response reinforces that it's really important to call 911 early. You can see here the Save Me. This is what we use to help people to train so that they can remember what to do. And there's a picture of this within the kit, so that actually reminds people if they're panicking. So firstly, it's to stimulate a sternal rub or call their name and shout. If they're unresponsive, then call 911. Check the airway, ventilate, give 1 breath every 5 seconds, and then evaluate. If they're still looks blue, their breathing isn't recovering, then administer the naloxone and draw up. If after 5 minutes they're not breathing normally, then evaluate and give a second dose. So we realised that not everybody calls the emergency services for help, and we wanted to explore why that was. So thinking about what we learnt with the mixed methods design, what sort of study is appropriate to find out who calls and why people don't. And these are the sequential mixed methods designs, just to refresh your memory: the explanatory design, the exploratory design, and the sequential embedded design. And then the concurrent and also the nested designs. We decided, because we were collecting data, we were collecting the administration forms, that we would use that as the basis to explore who was calling 911 and who wasn't. And then from those results we would do some focus groups and some individual interviews to explore the qualitative reasons that people could share with us. So we reviewed the Naloxone administration forms, starting from when the program first started in August 2012, right through until February 2015, so 2.5 years of forms. And what did we find from the administration forms? Despite our efforts emphasising the need to call an ambulance, only about 54% did. This proportion has increased over time. When we divided those 2.5 years into the first half and second half, we found that 41% called during the first half of the programme and 60% in the second half. So there was some improvement, but still not good enough. It also varied by overdose site. What we did find was that 80% of people, when the overdose occurred on the street, were calling 911, whereas 28% in private residence called. So it was considerably less when it was in somebody's private residence. When we actually asked what the reason for not calling was, one of the reasons was fear of the police. Another reason was thinking the person would recover. And then there were other reasons: not having a phone, didn't feel it was appropriate, those kind of things. So when we look at it by geography, we did find some considerable differences there as well. The lowest, the percent, this is with the police attending. So this, as you saw earlier, people who were not calling 911 were concerned about the police arriving. So this is a little bit more evidence to say what does actually happen. We found in interior that 62% of times when 911 was called, the police arrived. In Fraser and Island it was nearer to 50%, and in Vancouver Coastal it was below 40%. In most jurisdictions in BC, the police will attend when 911 is called. They're there to ensure public safety and also to ensure that the ambulance crew can do their job. Interestingly, this was an issue that had been brought forward previously, and the Vancouver Police Department have a policy of not automatically attending when an overdose call is put in. Only that if death, violence, or the ambulance asks for assistance will they attend, and hence you can see that there is a lower attendance by police in the Vancouver coastal region. So, getting back to who and where people call, so I mentioned that the setting was really important, and if somebody was in a single room occupancy hotel, 57% of people phoned, called 911. If it was on the street, it was 81%. So even not in private residences, there was a considerable difference. In private residence, as we mentioned before, it was much lower. If we look at who's calling, females are more likely to call than males. Seems to be evenly distributed across the ages. When we did a multivariable analysis, we found that the health authority difference was not significant. But compared to an overdose in a private residence, an overdose on the street, a person was more than 10 times more likely to call 911. So again, we wanted to explore what were the real concerns, what could we really do to address some of those concerns. And we decided that not just to interview people who use drugs and key informants, but also to have people from the police and to have their perspectives as well. The question guides were based on a literature review. This has obviously been studied previously, and also on the quantitative findings that we had. The interviews were audio taped and transcribed by verbatim. And the transcripts have been read through, and the research team met to discuss the themes. And I'm just going to present some of the provisional findings, because we are only just at the stage of doing this, so there's no paper that's been published. And as you know from learning about qualitative, it tends to be an iterative process, and things may change as we go through this. So some of what we heard loud and clear was the fear of arrest. And we also heard stories where people had been dragged out of residences into the street before 911 was called. So downstairs, just to make sure that the individual, when called, that the police, if they came, were not going to be attending at an individual house. There was a fear of drugs being seized, there may have been people using in a group and disrupting the group dynamic. When the police came, there's a process that they take names so that they can file a report. And this, obviously, people are very concerned about having their name written down as being there when an overdose occurred, and perhaps being connected with using drugs. And especially if somebody has been released from prison, they may be on probation, and if they have an outstanding warrant, they are at risk of having an arrest. There's also a loss of anonymity. A house might become known as somewhere where people inject. And we heard loud and clear that there was concerns about treatment by police, that the police may make stigmatising assumptions when they attend, and some police members can be confrontational. It was quite difficult to tease out from the focus groups whether this was really in reaction to being called around take-home naloxone and 911, or whether it was more of a historical feeling that the police had been confrontational in the past. Some did feel that the police were there for a good reason, and understood that it was the police were there to protect the safety of the people that were around. So we certainly are hearing that we need to increase the distribution of take-home naloxone, and this is especially true in the light of the recent overdoses and overdose deaths that have been occurring in relation to the fentanyl that's being cut into heroin, or in the fake oxys, or the fake 80s as they're called. So our next task is to work on increasing how can we encourage people to call 911. We need to look at the awareness of the police around the programme. When we first started with take-home naloxone, we heard that police were confiscating the kits. We've done lots of efforts to try and increase their awareness, but we still need to do more training as more sites pop up around the province. There's currently 88, but there's going to be more, obviously. There perhaps is need for police sensitivity training, so they respond appropriately. And we need to give people who use drugs the tools to know what's best to say when they're calling 911, which may prevent the police occurring. And we need to continue to monitor. So we'll be working with enforcement and people who use drugs to identify new initiatives and new ways to work together to improve the rate of calling of 911 when somebody is overdosing. The take-home naloxone program, this is from 2 months ago, and we know that the numbers have increased dramatically. We had been sending out about 500 kits a month, and we've had almost that number in a week just recently with the fentanyl alerts that have been going on. And we trained over 4,000 people, of whom over half are people who use opioids, but we're training their family and friends as well. And we've had to date at least 250 overdoses reversed, and I'm sure there'll be many more in the days to come. So I think this is an illustration of how you can use quantitative and qualitative data together to provide a better understanding of the research problem than either one would be able to provide. And the mixed methods design builds on the strengths of both the methods. Thank you.